I'm really going to piggyback on the last talk that we just heard about pain management and what the focus really at ONSF and the foundation that we've been dedicating a lot of our research efforts to the opioid epidemic and what we can do at our level to really reduce and stop it. So just some background on the opioid epidemic, and I read even more about this for this talk, and the data really is frightening the more and more you read. So it's truly a crisis. I think we're all aware of that. There's a rise in opioid addiction and deaths. More than 50% of addictions and overdoses involve prescription or pain medications. And 1/3 of the narcotics that are being prescribed are going unused for their intended use. That means they're in the medicine cabinet and they are being diverted for other uses, and usually not in a good way. There we go. So in 2014, there were more deaths from drug overdose than in any previous year. In 2015, there were over 50,000 deaths from overdoses. And in 2015, 276,000 abused prescription pain relievers. That's a huge number. And this is where, for me in particular with younger kids at home, gets scary. In 2015, an estimated 21,000 adolescents had used heroin in the past year. And we do know that a lot of these children or kids, adolescents, are starting with a prescription drug, and it's getting to the point of heroin. So that is where we play such an important role for this opioid crisis. And here's some more data that is really frightening when we're looking in the perioperative place. So after 1 day of narcotic use, there's an increased risk of long-term use. And this is, I'm going to go through sort of different things here, but at 1 year, there's a 6% increase that patients will be using narcotics at a year out if they've had 1 day of narcotics. And at 3 years, it's 2.9%. That's a scary number for 1 day of narcotic use. For a 1-week prescription, the increased risk of long-term use is 13.5%. And for a month prescription, the increased risk goes to 30%. And those are real numbers that we need to really address and be aware of. So where does the opioid dilemma come into play for us? Orthopedic surgery and orthopedic injuries are painful, and they're painful for our patients. And as orthopedic surgeons, we are aware of that, and we are focused on treating our patients, either their injuries or their perioperative pain. In 1995, the pain was introduced as the 5th vital sign. And that became, I think that complicated or made it difficult for doctors in a lot of different ways. We are very focused on controlling postoperative pain, but when you look at this scale here, I think it's, some of us don't really look at it that carefully. You kind of ask patients, how much is your pain, where's your pain? And the goal with that 1995 introduction was really to bring our pain down to a 0, to a 1. We wanted our patients to say none. As doctors, we're being evaluated on where our patients are stating their pain is after surgery. We want to go in there postoperative day 1 and we want a 0. And that's not realistic. But if you look at the scale even more carefully, 0 is none, 4 is annoying, but you jump up 2 to a 6 and that's dreadful. It's a really tough scale to follow, and I think it's a really hard thing to know where patients are. And we have to, kind of think about going from a 4 to a 6 goes from uncomfortable. I'm okay if my patients after a total shoulder replacement are a little bit uncomfortable the next day, but I'm not overdoing their narcotics. That's okay with me. If they're dreadful, that's not good, and that's only a 2-point difference. So it's a really hard scale, in my view, to look at. And here again, looking at the postoperative pain and how patients record it. So greater than 75% patients after orthopedic surgery report moderate to severe pain. And over 30% report severe to extreme pain. So pain is real, and we need to treat it and figure out a way to do it safely without prescribing too many narcotics. And currently, if you look, too many narcotics are being prescribed, and many of them are being diverted for non-medical use. And again, one thing that doctors are being evaluated on is how well we're controlling pain. We're not quite being evaluated yet on how well we are limiting or controlling our narcotic or opioid prescriptions. So there's this feeling that you want to make sure your patients are satisfied after surgery. And of course, it's incredibly important for all of us that our patients are satisfied, their outcomes and their immediate pain. But we don't want to make the mistake of giving that spoonful on the left, of giving them too many medications so that we get, an excellent response. So what have we done as a practice, as a foundation, to really approach this? One, and I think probably the single most important thing that I've done in my practice is to set realistic expectations after surgery. So I speak with my patients very openly about the pain that they will have. And I explain, I think the most important thing is that it's normal, and it does not mean that there's something wrong after surgery. Many of the phone calls I get after surgery is, I'm having pain, is that normal, is something wrong, did I tear this? And I think right up front, if we can tell our patients it's normal, it does not mean something wrong. Most of them will then say, oh good, the pain's not that bad. I just thought something was wrong. I don't necessarily need to take more, but it scared me. And so having that conversation in the beginning is very important. The second thing is optimizing our surgical techniques, and that's doing more minimally invasive surgery, faster procedures that have less pain postoperatively. And the third is really working with our anesthesia team on perioperative pain protocols that reduce the number of narcotics that we're giving. So prescribing habits of all of our doctors, and we've looked at that within our practice and through the foundation. One thing I've noticed in the last 6 to 9 months, I've started reducing my own prescriptions significantly for a knee scope from 20 to 5 narcotics. And I actually tell my patients, don't even fill it, bring it home if you need it. And since I've done that, I haven't had a patient take a single narcotic for a knee scope. That's a pretty significant change. And I don't think it's necessarily how many I've given them, but it's the fact that I've opened up that dialogue and discussed it with them. And they take that prescription home and they throw it away, and they don't even have those 5 that have been introduced into their home. So understanding that overprescribing increases the risk of diversion, that those pills are going to go not just for postoperative pain, but for something else, and often being abused. Another important area is educating our patients on drug disposal. And I tell my patients how they can do that if they do have extra pills postoperatively, what they can do with them. And a lot of patients just put them in the cabinet, throw them away, but just having that conversation I think is really important up front. And then again, improving our algorithms, and this is something that we're really doing through the foundation, so we have better postoperative pain management. We talked a little bit about some of the multimodal, so I know you guys have been here for a long time, I won't go through that again, but we are working very closely with our whole anesthesia team on multimodal approach and all the different medications that we can use in combination to reduce the need for narcotics and opioids after surgery. Exparel has been a really important part of our surgical approach, where it is a local injection that we're doing around the time of surgery, sometimes right before or at the end of a procedure, that has really reduced the pain that our patients are having. And I'm going to show you a video. Sorry, it's jumping. This is a patient of mine who has had bilateral total shoulder replacements. And he has given permission for me to play this video.
All right. So I'm just going to ask a couple questions about your shoulder, or both of your shoulders. So what procedure did you have done for your shoulders?
I had a total shoulder replacement.
Okay, on both sides?
Both sides.
Okay. And tell me, for each one, how long did you stay in the hospital?
2 nights the first time, but I really could have been out in one, and 1 night the second time.
Okay. And how much pain did you have after surgery?
For the first couple of days with the nerve block, I didn't have any.
Okay.
And then the pain was very manageable. I didn't take any pain medication.
Okay, so you took no pain pills at all for this surgery? Okay, great. And how are you doing today? Excellent. How about the other one? Excellent. Not doing any pull-ups, are you?
Actually, I do the assisted pull-ups.
Thank you.
So after his right shoulder was done first, and after that, the pull-up thing, he came in at about 3 months telling me he was doing pull-ups. I was like, please stop that. But the key thing with him, he had a regional block as well as Exparel on both of these shoulders. He took 0 narcotics after a total shoulder replacement. That's pretty incredible and remarkable, and tells a lot about what we can do and how we can improve our post-operative algorithms, our opioid prescriptions, and how we can have an impact here. So again, the final thing through the foundation, through our practice, what are we doing? One, we're establishing multimodal pain management algorithms. And through our foundation, we're doing a lot of work on that so we better understand each patient, risk factors for patients having higher pain, and what we can do to really to treat that appropriately. Using perioperative slow-release injections like the Exparel, we are ultimately providing better outcomes and less pain in our patients and prescribing less narcotics, and that's really important. And we're changing our prescribing habits. We all, as Dr. Ahmad just said, and I had the privilege of training with him at Columbia, it's so important not just to practice, but to reflect and to really criticize yourself or critique yourself. And we have, as surgeons and doctors at ONS, we have stopped and said, how are we doing on prescribing? And I think a lot of us said, I think I'm prescribing too many, and we really have changed a lot of our own prescribing habits and reduced the number of narcotics that we're introducing to our whole community here. So my final thing is, as I left this morning, I told my 2 kids that I was dedicating this talk to them, and I think there really is no other topic that is more important to dedicate to our kids, and that is why all of us in this room as healthcare providers have such an important role that we can really impact this epidemic, and we can reduce the number of narcotics we're introducing. As important, we can share with our friends, our families, our patients that they don't need as many narcotics, and if they have them, how they can dispose of them, and if they are using them, to kind of be comfortable with that discussion and that it's not okay and how to get off faster. So I think it's really up to all of us in this room to take some responsibility and to take some initiative in this epidemic so that we can look at our kids and know that we have really hopefully reduced that risk that someday that they'll run into that. So thank you very much.